in this cold. I nearly didn't come. But how do I do this? How do I change slides?
Can you change slides?
Yeah.
The right arrow. Ready? There we go.
There we go. Okay. Thank you. Okay, so basically tonight I'm going to be mainly focused on your first upcoming path exam. So like resp, endo, renal, breast. And then we're going to go through a couple of OSCE stuff. And then in the second half, we'll do heme and skin. But I haven't actually touched on MSK just because I don't think we'll have the time. So yeah. Okay, so for resp. Basically, these are little slides of your normal lung microanatomy. So these, is there any way I can?
You can use the mouse
On your laptop?
Yeah.
Ooh. Oh. Okay, perfect. Thank you. Perfect. Thank you. Okay, so that's basically your alveolar structures, and these are your ciliated bronchiole lining. So just in terms of your microanatomy of the alveolar themselves, so you have your type 1 pneumocytes. They cover about 95% of your alveolar lining. So these are like your epithelial, endothelial cells. And then you have your type 2 cells, which is your surfactant releasing cells. They don't cover much surface area because the cells are more cuboidal, but they do account for about 60% of the actual cells themselves. Your last cell type are your macrophages, and those are also part of the lining. So basically, and then beneath that you have your capillaries. So basically the barriers between, barriers between your gas and your blood are your pneumocytes, the pneumocyte basement membrane, the endothelial basement membranes, and your endothelial cells. But your two basement membranes are basically fused together. In terms of the epithelial lining of your bronchioles themselves, so they are lined with pseudostratified columnar ciliated epithelium and goblet cells. So basically what happens is these ciliated cells and your goblet cells form a mucociliary blanket over the actual airway epitheliums, and the cilia slowly beat the mucous blanket towards the trachea, and therefore like cleaning your lung as it is. So as the bronchi branch further in, so as you get deeper into the lung, you have less epithelium, and it becomes thinner and thinner until there's only one cell layer left. So, and then you don't have your, you lose your cilia as you go further into the lung. Okay, so I don't know how many of you guys had a chance to go through those questions, but so in terms of this question, does anyone kind of want to answer? No. Okay, let's go through okay, this one. I don't know whether to be really mean and go around, but I think I'll will. Okay, so basically the answer to that was COPD. So basically, emphysema, and it's a matter of determining whether it's centrilobular or panlobular. So basically COPD is a disease of your alveoli themselves. So in terms of emphysema, that's a disease of your alveoli themselves. So basically, if you compare this to the slide that we saw just before, you can see that there's a lot of breakdown of the actual alveolar walls. So your lung ends up less spongy, and that's kind of shown in this fresh specimen. And you have destruction of alveolar walls as well as dilated air spaces, which result in your gas trapping. So in terms of smoking versus alpha-1 antitrypsin, can anyone tell me what's
the centrilobular?
Yep.
A180 is
perfect. Thank you. So now moving on. So okay, so the structure of this lecture, because you guys have covered a lot of the background through the other slides and through your other learning outside of PATH. So I'm really gunning in for like the buzzwordy PATH stuff. So I'm not really giving too much context to this. But can anyone tell me the answer to this? I think I can hear it being whispered. Anyway, so the answer is silica. But essentially, we're talking about fibrosis and interstitial lung disease. So the causes of fibrosis can be split up into your upper and lower lobes. And I'm not sure whether you guys have covered this before, but this is something that I've definitely never memorized. So you can break it up into a mnemonic, so charts, ratio, bam, which makes no sense whatsoever. So I don't know how the mnemonic helps. But in terms of the actual upper lobe fibrosis, so you have choleworker, histiocytosis, aspergillus, angstbon, radiation, TB, silicosis, sarcoidosis. And in terms of your lower lobe, you have like your RA, asbestos, scleroderma, and like other idiopathic. So idiopathic interstitial lung disease and meds. So those three medications in particular do cause fibrosis. So this is something that's worth kind of knowing, just so that if you ever get a question that tells you that the fibrosis is in the upper lobe, you can kind of break it down and you don't have that much to go to choose between. Yep.
So we would call it the rule of opposites. So coal and silica comes from the ground, so it's upper lobe fibrosis, and asbestos comes from the ceiling, and coal causes lower lobe fibrosis.
That's really cool. That's a really good one. Thank you. Okay, so can anyone hazard a guess?
Please.
Yeah, perfect. Okay, so in terms of the causes of pneumonia, you have, like, these are basically the buzzword causes. So like if you have an alcoholic sputum that looks like red currant jelly and dysphagia, you're looking at a Klebsiella type picture. For any immunocompromised, particularly HIV, you're looking at PCJ. With elderly, air conditioner caused, and if they have an extra symptom of diarrhea, that's a very Legionella picture. Rust-coloured sputum is strep pneumoniae, and if they have CF, so like bronchiectasis, they're going to present with Pseudomonas. And if they're unvaccinated, you just go with Haemophilus. Yeah, and smokers get Staph aureus. So these are kind of things that you should kind of try to remember just before the exam. Yeah.
Sorry.
Yep.
The diarrhea and the
Yep. So Legionella, they tend to present with diarrhea as well as the pneumonia type symptoms. So that's the only pneumonia that also has a symptom of diarrhea. Yeah. Okay, so this question. So basically there's a lot going on in the question, but basically it comes down to a high serum calcium and which lung cancer is associated with high calcium. Yeah, perfect. Cool. So in terms of lung cancers themselves, squamous cell. Yeah. So in terms of lung cancers, you have your adenocarcinomas, which are your most common lung cancers, but they also have the highest association with non-smokers. I mean, it kind of makes sense if they're the most common. So if a non-smoker presents with symptoms of lung cancer, you would always go with adenocarcinoma. The paraneoplastic syndromes, so because pancreas tumours are adenocarcinomas, they are associated with Horner syndrome. And what are the three standard features of Horner syndrome? So ptosis, meiosis, and anhidrosis. So that's your classic Horner syndrome picture, as well as HPOA, and when HPOA includes clubbing, but I just put it there just because in case you, like me, didn't realise that. Squamous cell carcinomas, those have the highest association with smokers, so and they present with hypercalcemia. Small cell carcinomas are the group of carcinomas with the greatest paraneoplastic syndromes. So you have your ectopic ACTH, your ectopic ADH, and Lambert-Eaton myasthenic syndrome. But they don't tend to have clubbing, which is interesting. So in terms of Lambert-Eaton versus myasthenia gravis, what are the main differences and how do you tell them apart?
Myasthenia gravis is where you get tired.
Yeah. Yeah, perfect. Okay, and do you guys know what myasthenia gravis is associated with? Yeah, but there's a particular tumour. Thyromas. So if you see a mediastinal mass, and they have neurological symptoms, you would go with myasthenia gravis. Okay, so endocrine. Oh, by the way, if you guys have any questions, feel free to ask as we're going along. So this question. Sorry?
Oh, okay. D.
Yeah, perfect.
So this is the pituitary adenoma with prolactinoma.
Yes, yes. Perfect. Okay. So in terms of your pituitary, so you can divide them into two portions. So your anterior, posterior. Posterior is connected directly to the hypothalamus. So the hormones from your anterior are GH, FSH, LH, TSH, and ACTH. And posterior are ADH and oxytocin. So the thing with the pituitary is that because it's in such a tight space, because it's so tightly encased by the cella turcica, you end up with any small lesion, any small tumour or growth will cause an effect on the cells there. So pituitary adenomas themselves make up 10% of intracranial neoplasms. And so in terms of clinical manifestation, so they can be a single hormone overproduction or a single hormone underproduction, just depending on which bit is being squashed, essentially. And you can have mechanical effects based on its location. So what's the classic sign of a pituitary adenoma? Yeah, good. So you lose your peripheral vision gradually. Okay, so in terms of the types of adenomas, you have your most common type, which is a prolactinoma. That causes galactorrhea and menstrual disturbances and therefore causing infertility. So just because of the menstrual disturbances, you get infertility. GH secreting, so like acromegaly, gigantism. ACTH, so Cushing's disease. And any others are pretty rare. So those are pretty much the three that you need to know. Now, this question. Can anyone hazard a guess or tell me the answer? Okay, so basically it comes down to distinguishing between the cortex and the medulla and knowing which hormones come from where. So
is this CAH?
Yes.
So is it just B?
Yes. Yeah. So basically, the reason, this is basically caused by a 21 hydrogenase deficiency, which causes increased in androgens. But if you break it down, if you didn't know that, if you broke it down just based on the actual hormone secreted, you can pretty much work out that it's a cortical hyperplasia without knowing the reason for it. So adrenal glands, they sit on top of your kidneys. And so this is what normal adrenals look like, just for comparison later. So in terms of the cortex, so the cortex is closer to the capsule, and so they both start with C, and medulla's in the middle. So your cortex is made up of your zona glomerulosa, fasciculata, and reticularis, and that is basically like your GFR. And then each layer produces your salt, sugar, and sex. So salt are your mineralocorticoids, which then go on and produce aldosterone. Sugar, glucocorticoids, and sex are your androgens. In terms of the medulla, so it's a neural crest origin, and they basically secrete your epinephrine, your norepinephrine, and your dopamine. So, but I think the main focus is really on your epinephrine. So in terms of like fair chromocytomas, they basically result in a sympathetic overload. So you have like headache, sweating, tachycardia, like everything's just, it's like anything sympathetic and like fair chromocytoma, like they produce very, very sympathetic driven symptoms. And neuroblastomas, that's your classic picture of a kid who has an abdominal mass with very few other symptoms. And yeah, so that's basically that, but that's more for next year. So this is what they look like. It's lovely. And neuroblastomas. And your cortex. So if you have a hyperfunctioning cortex, you end up with hyperaldosteronism, which is cons, or Cushing's, or hypersecretion of sex steroids. So you can kind of break it down just that way. And that's what an adrenal adenoma looks like. Okay, this question. So the key points to this question are that there's a gradual feeling of fullness and no other concerns. So she's pretty much asymptomatic. The other key point is that she's from Nepal, and she has a diffusely enlarged thyroid with no masses, no lymphadenopathy, and TFTs. Yes.
Why is she iodine deficient?
It's just like a classic. It's just a thing. Like that's why if someone's in a particular country or from a particular country, you got to work out like why are they from that country? Because there's a lot of racism going on. So basically it's just a non-toxic goiter secondary to iodine deficiency. So in terms of the causes of a goiter, if it's a diffuse goiter, and the person has hypothyroidism. So the most common condition is Graves' disease, and your drugs that can cause it are iodine and amiodarone. Amiodarone can cause either hyper or hypothyroidism, so that's not particularly helpful, and subacute thyroiditis. So that is transient hypothyroidism followed by hypothyroidism. In terms of hypothyroidism, you can have Hashimoto's, or again, drugs, and Rydell's thyroiditis. If they're euthyroid, but they have a goiter, so things like simple goiter, or iodine deficiency, and infiltrative diseases, so like amyloidosis, sarcoidosis. So goiter, break it down into their symptoms, and then break it down from there. If it's a multinodular, then they have a multinodular goiter. There's a simple thyroid nodule. It could be just a cyst or a colloid nodule. And then you can go into your cancers. So they're follicular, papillary, adenomas, carcinomas, medullary, anaplastic, and lymphomas and Mets themselves. So we'll break it down more. In terms of Graves' disease, so that's the most common cause of endogenous hyperthyroidism. It's caused by autoantibodies to your TSH receptor. So thyroid stimulating immunoglobulin binds to your TSH receptor. So if you think about the actual name itself, considering it's thyroid stimulating, you can kind of work out that that's the antibody that causes Graves' disease. So this is kind of what it looks like on a slide. I'd never really bothered memorizing what each of them looks like, but I guess if you want to, like, you can come back here for reference. So in terms of the Graves thyroid picture, you have a very diffusely enlarged, smooth thyroid gland. And so for your multinodular goitres, those are also very, very common. It's basically a result of recurrent hyperplasia and involution. So you end up with little nodules. It's asymmetrical, and you can actually feel the nodules. Sometimes you can have a dominant nodule, which can be mistaken for a solitary thyroid nodule, but then when you feel more and then you realize that the nodule's everywhere, then you go to your multinodular goiter. That's kind of what it looks like. It's very, very pretty. And there are many different sizes of cysts, and some are like different colors. Yeah. If you see a thyroid with a lot of nodules, just go with multinodular. Hashimoto's, so that's, and again, another autoimmune disease resulting in destruction of your thyroid gland. So it results in a thyroid gland that's diffusely enlarged. It's kind of like the Graves for hypothyroidism, and I think you guys would already know all this stuff. But in terms of the path, so you have destruction of follicles, and you have little Hürthle cells. So so basically what happens is your thyroid epithelial cells enlarge, and then they develop like eosinophilic granular cytoplasm, and then you have Hürthle cells.
Is it metaplasia essentially?
Yes. Yep. Yep.
It's like Barrett's esophagus for the thyroid.
Yeah. Yep. And sometimes there's fibrosis as well. So like Barrett's esophagus plus fibrosis for the thyroid. Yep. And yeah, so basically your follicles are atrophic, which results in your hypothyroidism, and you get instead the Hürthle cells, which don't do anything, and fibrosis. Okay. So yeah, so your gland is slightly enlarged, and that's pretty much what it looks like. Okay, so Quervains, I'm terrible at pronouncing these stuff. So it's more common in women, so that's your hypothyroidism. So it causes thyroid pain, and you end up with non-necrotizing granulomas and giant cells. So that there is your granuloma. Okay, so getting on to the cancers. Anaplastic? Yeah, perfect. So basically, these are the 4 cancers that you kind of need to know. So starting with anaplastic, so that's your worst prognosis, and you have giant cells and spindle cells on histology. They metastasize really quickly, and they're just not fun. So in this case, he had spindle cells, he had Mets, and he had a lot of extension. It seemed to be fast growing. So that's your anaplastic picture. In terms of papillary, so it's the 5 Ps. So it's the most common, so it's popular. You have palpable lymph nodes. You have positive radioactive iodine uptake, as well as a positive prognosis. And you do a radioactive iodine scan post-op just to check that you've essentially got rid of the cancer. In terms of histology, so you have your orphan Annie nuclei and Pneumoma bodies. So your orphan Annie nuclei look like that. So there. Okay, so in terms of follicular cancer, so that's the 4 Fs, so they're far away Mets. Females tend to get this. FNA really doesn't work, but it's also a favourable prognosis. And so on histology, like the classic buzzword would be blood vessel invasion. And medullary, so you have your 3 M's, so multiple endocrine neoplasia, amyloid, median node dissection. So if you have cancers in the lateral cervical nodes, that's when you do your median node dissection. And you tend to see like amyloidosis on histology. So that's your picture of follicular carcinoma. And that's your anaplastic. So these are your spindle cells there. Okay, so now we're moving on to renal. So in terms of this question, all right, so first of all, what sort of GN does he have? Sorry? Yep, perfect. And out of the nephritic syndromes, do you know which one he would have? Sorry? Okay, so the things to pick out of this question are the fact that he had dark red-brown urine 4 days after a mild RESP infection. If I said it was coat-coloured urine, would that help?
Coat colour doesn't change much, actually. Any hematuria has coat colour.
No, but that's the classic buzzword for this. Okay, so it's basically IgA. Male coat-coloured urine. If he's Asian, that would point you even more towards IgA. And it's only 4 days after a mild ERDI. So, yeah, so basically the answer to this question would be C, so mesangial IgA staining by immunofluorescence, just because he has IgA nephropathy. So, in terms of the renal conditions, there are quite a few to know, but they're not too hard to remember because you really only need your buzzwords. So we'll just start with your nephrotic syndromes first. So you have minimal change, which is your childhood nephrotic syndrome. Like you pretty much, like your picture would be a kid comes in slightly swollen, normal, like fairly normal renal function, no changes on light microscopy, and podocyte effacement on electron microscopy. And that's like your minimal change picture, and they tend to get better, like pretty, they tend to get better. FSGS, that's your basically minimal change disease for young adults. It's a little bit worse. They have segmental sclerosis on light microscopy and podocyte effacement again on electron microscopy. And that on immunofluorescence, they have IgM and C3 segmental distribution. So for membranous, that's kind of like one step further along, and it's a nephrotic syndrome in adults. So again, like age difference, they're getting older, it's getting worse. GBM spikes on silver stain and podocyte effacement and IgG and C3 granular deposits. So then your last nephrotic syndrome is your diabetic nephropathy, and you have Kimmel-Still-Wilson nodules on light microscopy. So those are your nephrotic. This is your nephritic now. So now you have your post-strep. So that comes 2 to 6 weeks after an infection, and it's most common in children. You have subepithelial deposits on light microscopy, but I think the thing to remember most is your starry sky on immunofluorescence. Like that's your classic buzzword. But if you have a kid coming in 2 to 6 weeks ago, had some sort of infection, generally a RESP infection, they have post-strep. IgA, that's during or immediately after. So like in this question, he had it 4 days after an ERDI. So it's already painting an IgA picture. They tend to be older than post-strep, and you have basically IgA on immunofluorescence. Membranoproliferative, so that's kind of like a mixed, it's both nephritic and nephrotic, and you have tram tracking on light microscopy, and that's the classic buzzword for membranoproliferative. And then finally anti-GBM. So you have crescents on light microscopy. Again, that's the classic buzzword of that, and then you have your electron and immunofluorescence. But so the thing is, do you guys know the difference between this and good pastures? Sorry? Yeah, perfect. So anti-GBM is basically the renal, just purely a renal picture. Good pastures has both anti-GBM and lung involvement. Yeah. Okay, so now moving on to breast. Okay, so just in terms of anatomy first. So it's basically a modified sweat gland. You have glandular, fatty, and fibrous tissue. And your main, so the breast is basically made up of lobules and ducts. So in terms of the lobules, so they're secretory units. So you have acini, which are glands, embedded within your tissue, your loose connective tissue, and they connect to the ducts. So basically, each acinus has two cells, so epithelial cells, and those are the ones that essentially synthesize your milk, and myoepithelial cells, which contract and result in ejection into the ducts. And so those little ducts connect to a larger duct called the terminal ductal lobular unit when it's combined with the lobule itself. In terms of ducts, so you have your extralobular ducts, which connect into and make up your subsegmental ducts, which then connect and make up segmental ducts, then connect lactiferous, and then they're essentially ejected into the nipple. And so that's kind of the structure of how they go. I don't think you guys need to know this, but it's more like, you know, if you're interested. So in terms of common clinical problems, there are three main things. So people present with lumps, pain, and nipple discharge. So if someone presents with a breast lump, the things that you would kind of consider are cancer, obviously, cyst, abscess, fibroadenoma, fibrocystic change, fat necrosis, and lipoma. So those are your main differentials for anyone presenting with a lump. Some obviously more common than others, and some more worrisome than others. So if anyone presents with a breast lump, what are the three things you need to do? Yep. 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 What are the scans? Perfect. Yeah. So basically, if they're young, you go with an ultrasound. If they're older, you go with a mammogram, and you would also do a biopsy, so like an FNA. So in terms, if someone presents with pain, the first thing that you actually suspect is pregnancy. And you can have cyclical mastalgia or mastitis itself. And in terms of nipple discharge, again, you suspect pregnancy, duct papillomas, duct ectasias, mastitis or abscess, or ductal carcinoma inside you. So those are your differentials, and we'll go a little bit more into them. Sorry? So it's basic. So mastalgia itself is breast pain. And it's just cyclical, so to do with the cycle. All right, what are you guys thinking? Yep, cool. So it's basically a trauma-related breast lump. So it's usually a discrete lump. yeah, again, after trauma, and it tends to last a while. I have seen a woman with multiple like fat necrosis, and it was like very, yeah. And it's hard to differentiate from a carcinoma, and that actually causes problems later down. But anyway, so in terms of macroscopically, it's yellow, hemorrhagic, some calcification. You can also have fibrous tissue, and histologically, you have macrophages and giant cells. Yeah, so basically anyone post-trauma, fat necrosis. Yep. So, fibrous connective tissue, cysts, fibrocystic change. So they usually occur in youngish women. So they tend to peak just before menopause though. In younger women, you can have a tender area, like generally premenstrually, it gets a little bit tender, diffuse nodularity, and it tend to be up to about 5 millimeters. Yep. For women near menopause, so it's an ill-defined rubbery mass, but you have to always do further investigations, obviously, and so they have fibrosis and cysts on histology. There's a discrete swelling, so you would be thinking towards cysts. Yeah, so that's kind of your fibrocystic change. So you have your cysts there, and like your hyperplasia. Yep. Yes. Yep. So basically, fibroadenomas, they're the most common benign breast tumours. They usually peak in women in their 30s. So they have hormonal influences. So if someone's pregnant and they have a breast lump, it's likely to be fibroadenomas. Generally, they're solitary, and they arise from the actual breast lobule itself, and they can involve both connective tissue, stroma, and glands. So they can become fibrotic and calcified after menopause, and so you can actually pick them up on mammograms. Just in terms of how they look, they are well circumscribed, and actually, like on exam, they're mobile, so they have a nickname of breast mouse, which is very strange. On histology itself, they have duct-like structures and basically overgrown connective tissue masses. Sometimes a lobular carcinoma will involve a fibroadenoma, so sometimes you can actually have neoplastic changes as well as the fibroadenoma. So that's what it looks like from the outside. Smooth, well circumscribed, lobulated. And that's what it looks like on histology. So you have your elongated duct structures. So in terms of the duct papilloma now, they are less common than fibroadenomas, but they're the most common cause of nipple discharge. So if anyone comes in with discharge, and which can be bloodstained, you would be thinking duct papilloma. Obviously, you would test for cancers, but that would be your most common cause, and it tends to be in middle-aged women. So in terms of how they present, sorry, that's not clinical features. So in terms of how they look macroscopically, so they can be elongated, extending along a duct, kind of like pink or white outgrowths, but it's usually within one large duct. And in terms of histology, so they're basically benign, so not pre-malignant, no risk of carcinomas. They just have, like branching fibrovascular cores covered by epithelium. So that's how they look. So in terms of carcinomas now, it's the commonest type of malignancy in most women. 80% occur over 50, so age is a risk factor. In terms of risk factors, so being female, like the older, the higher risk. Long interval between menarche and menopause. So this is an estrogen-dependent tumor. So you have, like, the longer you have estrogen, so like, long time of menses, older age at first pregnancy, obesity, and then just in terms of exposure, so radiation, geographic factors, and history. So if they had a history of benign breast disease, if they have a family history of breast cancer, so those increase your risk. So what are you guys thinking about this? So basically, she's 60, ill-defined 1 centimeter mass, upper outer quadrant, which should already be kind of ringing alarm bells. And on FNA, while she has predominantly fibrocystic changes, there are features of malignancy. So you already know it's a carcinoma. And it has predominantly fibrocystic changes. And fibroadenomas are commonly associated with lobular carcinomas. So just based on that, B would be your answer. So in terms of non-invasive carcinomas, so basically what they essentially mean is that there's no evidence of penetration through the basement membrane. So they're very, very well, essentially well encapsulated. There are two types of ductal carcinoma in situ and lobular carcinoma in situ. So just talking about ductal carcinoma in situ, usually they're in the 40 to 60 age group and can present as a palpable mass, but they're often not palpable. They're only palpable if they're actually associated with fibrosis or if they're very extensive. If they're larger ducts, so you can have a nipple discharge or like Paget's disease. On mammogram, you have linear calcifications, and on histology, you have small and medium-sized ducts, and they can have a central necrosis, calcification, or just like appear solid on histology. So that's basically what it looks like. So that's your area of necrosis and calcification. Yeah, and so that's showing that basically your basement membrane is intact. In terms of your lobular carcinoma, that occurs more frequently in premenopausal women. So it can be bilateral. So if someone presents with a bilateral carcinoma, you'd be thinking more of a lobular carcinoma in situ. Histologically, changes are in the acini themselves, and the normal cells are replaced by relatively uniform cells, clear cytoplasm, and only a quarter to a third who are treated by biopsy alone go on and develop invasive carcinoma. So they're not particularly bad. So in terms of, so that's basically how it looks. Expanded acini, loss of lumen. All right. Yeah, perfect. So it's basically, invasive. In terms of the different types of invasive carcinomas, so basically, well, all it means if a carcinoma is invasive is that it's broken through the basement membrane, and that's the reason for your nipple retraction as well as lymphadenopathy, because it's actually spreading. So your histological types, so 75% are of no special type, which I found quite funny, because it's kind of sad. You have infiltrating lobular and all the other types, but basically the most common one is infiltrating ductal carcinomas of no special type. So for clinical presentation, so they can be firm on palpation, they could have tethering, dimpling, nipple retraction, so anything that demonstrates that there's spread beyond just the ducts or lobules themselves is going to be an invasive carcinoma. So you have a hard, painless, palpable lump, usually upper outer. On mammograms, your mass has fine spikes radiating around the edges. On biopsy, the thing to keep in mind is that they're lacking a myoepithelial layer. So again, remembering the myoepithelium are what essentially ejects the milk. So that's actually completely gone in invasive ductal carcinomas. And then the enlarged hyperchromatic nuclei and prominent nucleoli, those are very key features of all cancer. But yeah, so just keep in mind the myoepithelial layer. Yeah, so that's basically a picture of a invasive carcinoma. So Paget's disease, that's basically the nipple spread in a cancer. So you can be scaly, raw, vesicular, ulcerated, painful, erythematous, and sometimes there's a bloody discharge. It's usually unilateral, and there's generally a ductal carcinoma present. So that's Paget's disease. Like, those are different versions of it. It's not very nice. And so finally, mastitis. So that's basically inflammation of breast tissue that may or may not be accompanied by infection. Generally, your picture is a breastfeeding woman, although it doesn't always have to occur during lactation. That's the general picture. It may not resolve with antibiotics. Generally, that's if there's an abscess that's formed as a result of mastitis, and that will actually need surgical drainage. And yeah, it's not always accompanied by an infection, but it generally is. That's like a picture of mastitis. Okay, so we're not doing too bad for time. How are you guys feeling? Do you want to keep going, or do you want to watch like a short video? Keep going, short video.
You can watch the video if you want.
I don't mind.
Anyone?
No, it's just like
Oh.
stupid. It is not. I was bored. All right, let's keep going. So, in terms of OSCEs, now if they threw an OSCE on you, I reckon that would be really unfair considering just how much path you guys are assessed on. But they can throw in an entire station on it. So it could be describing and analysing a specimen or reading a report. Like, I mean, reading a report is literally reading out the report. That's not too bad. And sometimes they can have focused questions. So that's at the end of the station. And it would just be like clinically relevant pathology. So anything that we've covered, anything that you guys have covered, it's fair game. So in terms of describing a specimen, there's basically a sort of structure, like you should come up with a structure to describe it. This is the one that our tutor taught us. So in terms of, first of all, so one of my friends described it as starting large, going small. So first of all, you start really, really big. Any patient details, so like Mr. X, whatever, what organ it is, that's actually sometimes strangely hard. I'm pretty sure there was one past OSCE where everyone said it was something completely different to what the organ actually was. So tried to be able to identify organs, how it's presented. So like if it's like a fresh specimen, is it sectioned? Is it stained? It's generally H&E staining, not always. But if you're not sure, just go with H&E. Then you move on. So you go a little bit so you've gone a little bit narrower now, talking about the normal anatomy. So this is something that people tend to forget. Just describe anything you possibly can. So anything that you can point out, anything normal. So I tried to have a system, so like either left to right, outside to inside, like big to small, whatever. Talk about size, shape, symmetry, borders, color, anything, like locate landmarks, anything. Just like keep talking, basically. Just don't shut up. Then you move on to your abnormal anatomy. Once you've run out of things to say that were normal, so when you're talking about the normal stuff, it's as if you don't notice the abnormal stuff. So just like completely skip over it. Then you go into your abnormal. So that's like one step narrower. Talk about, so if it's a lesion, talk about the anatomical location, the number of it. So if there are multiple lesions or it's a single lesion, the size, shape, borders, whether, so basically shape. So like, is it symmetrical? Is it asymmetrical? Borders, infiltrating, is it encapsulated? Features, so ulceration, hemorrhage, necrosis. So by this point, you should kind of have an idea about what the disease mechanism behind it is. So if it's something neoplastic, just go with all your neoplastic buzzwords. That should get you the marks. So if it's malignant and if it's on a histological slide, so you can go with, so those are pretty much things to say. So abnormal, pleomorphic, hyperchromatic, nuclei with atypical mitosis, irregular border, that's infiltrative, poorly differentiated, and it's in stark contrast to surrounding cells. And so that's pretty much what you would say for any malignancy. And then only then do you move on to like potential diagnosis. So actually getting the diagnosis is not that important, as you guys would know with all OSCEs. It's going through the whole process. So basically think about your vascular causes, think about your autoimmune causes, your metabolic, degenerative, and neoplastic. So those will be your main ones. And then relate it back to what you've seen so far. And then finally, definitely don't forget correlating it to clinical information, because that is really, really easy marks. So if there's no clinical information given, just say, I would like more information to relate this to the pathology, because you can't really make a diagnosis without knowing exactly what person presented with. Otherwise, correlate it to the clinical information. So that's pretty much describing a specimen. In terms of reading a report, so you literally read it. You read the patient details, you read everything, you read the clinical picture, what they presented with, you read the procedure details, you read the microscopic findings, and if they're given a provisional diagnosis, you also read that. And then by that point, you know that you've got like substantial marks just by, going to primary school. And then you bring it together. So give your provisional diagnosis, say what supports your provisional diagnosis, and again, relate it to your clinical picture. But again, there's nothing too much to think about in this particular station. Okay, so now moving on to hematology. Okay, so that is, I really, really hate this picture. But basically, so you start with your stem cell, and then you go, and then that basically splits into either a myeloid or a lymphoid. Oh, gosh. Wait, what did I do?
Right across it is a colon.
What?
Colon.
That's a thank you. So basically, myeloid versus lymphoid, so it's interesting note that red blood cells, mast cells, and platelets all come from a common myeloid progenitor, as well as your myeloblasts, so like the stuff that you're used to, so basophils, neutrophils, eosinophils, and monocytes. So basically, if you have a, like you can have a myeloid cancer of any of these, and well, yeah, pretty much same with lymphoid. So you can have your natural killer cells or your T and B lymphocytes and your plasma cells. So it basically depends on at what point did the neoplastic process occur, and that would tell you whether or not you have an increase or a decrease in your red blood cells, your mast cells, and your platelets. So you know how like with any leukemia, you can have either a really, really high number of like a high red blood cell count, a high platelet count, or you could have really low red blood cell or platelet count. So that's the reason why, because it really depends on at which point did the cancers start occurring. So in terms of lymphocyte development, just going back to like first year, second year, your immature lymphocytes are formed in your bone marrow, and your T cells go to your thymus to mature, and they then go to your nodes. So helper cells are CD4, killer cells are CD8, and your MHC for each of them, CD4 is MHC2 receptor, CD8 is an MHC1. And B cells go straight to your nodes, and they're CD20. Cool. So, have a go at this question. Okay, so basically what's happening is, so the main thing to get from all of the words are that he has blasts. And the cancer which has blasts, so basically you have CML or AML which present with blasts. Now CML is chronic myeloid leukemia. Your Philadelphia chromosome is present. That's a very buzzwordy feature. And you have three phases of CML. So your chronic, which is less than 10% blasts, accelerated, and blasts. Now, this can progress into AML, which is the more aggressive form, and you have our rods and blasts present. And so that's why the answer to this was our rods. So in terms of other myeloid neoplasms, you can have polycythemia vera and essential thrombocytopenia and myelofibrosis. All of those are like related to JAK2 mutations. And polycythemia vera, you have a high red cell count. Essential thrombocytopenia, you have a high platelet count. Myelofibrosis, you have tear cells because your bone marrow is crying. Very sad. Now, this one.
So what was the answer? Sorry.
Our rods, because there were blast cells, and so the only correlation would be our rods. Okay, so basically the key to this is these little cells, and they're called smear cells. And that is a chronic lymphocytic leukemia picture. So in terms of ALL and CLL, so ALL is a childhood leukemia. So if a kid comes in with some sort of a leukemia, you would pick ALL, basically. For CLL, that those are your bunch cells. Pretty sure they're smear cells. Anyway, so you have a rule of thirds. So you can either have no treatment, slow disease progression, or aggressive progression. So a third will require no treatment, a third will have slow disease progression, and a third will have aggressive progression. And that's the most common adult leukemia. So CLL is the most common adult, ALL is the most common childhood. All right, spot diagnosis. Yeah, and what are they called? Perfect. So this is a B-cell lymphoma. It's got a good prognosis, and you can have nodular sclerosis, mixed cellularity, and lymphocyte depletion. And you basically have Reed-Sternberg cells on histology. Now, the difference between leukemias and lymphomas. So leukemias are proliferation of immature cells, while lymphomas are proliferation of mature lymphoid cells. So lymphomas stay only in the lymph nodes, and they don't actually spread into the blood as much, while leukemias are basically, because they're immature cells, they can spread throughout your blood. So myeloid versus lymphoid, and yeah, and acute versus chronic. So this is just kind of like a summary type slide. So now, talking about lymph nodes. So basically, your afferent, so lymph basically comes in through your afferent tract, and it goes through your cortex into, like, through your medullary cords and out the efferent lymphatic, and it goes out the efferent duct. So basically, what you have are your cortex, and that's basically where your B and T cells are. So your follicles are where your B cells are. So mantle zones and marginal zones have your naive B cells, and so they have not actually gone to your germinal centers, while in your germinal center, they're proliferating B cells and helper T cells. So basically what happens is this is the germinal center, and this the rest of your cortex, and so basically your B cells are maturing slowly as they go along that way. Now your paracortex is where your T cells are, like proliferating, resting, chilling. That's basically there. So your B cells kind of like progress this way, and your T cells kind of chill there. Now, and then in your medulla, you have your plasma cells and histiocytes. And so, yeah, basically your lymph goes through all of those regions. Now, your, yeah, so basically this is just restating what we've talked about. Afferent through the lymph node, efferent out the other way. So in terms of the features of nodes and like what they relate to, so if you've had a long history of painless enlargement, that's pointing towards a low-grade malignancy. Short, painful history, it's pointing towards an infection. It's a soft, rubbery lymph node, that's a lymphoma as a buzzword. Firm and hard is a MET. Generalized versus local. So if it's local, it could be a tumor or infection, whereas if it's generalized, you're thinking more of a systemic virus or lymphoma or leukemia. Okay, so moving on to skin, and this is the last section. So histology. So you have your epidermis, and yeah, and then you have your dermis, and that's your papillary layer, and then your reticular layer of your dermis. Now, breaking it down more in your epithelium, so you have your, so it's like a little mnemonic, come let's get sunburnt, which is very cute and ironic. You have your corneum, lucidum, granulosum, spinosum, and basale. I don't really know how important it is to memorize it, but it's kind of like Yeah, if it's easy to memorize. Yeah. So now skin conditions. Okay, so she's 15. This scattered light brown everywhere. Increase in summer, fade over winter, don't itch, bleed, hurt. Most likely diagnosis would be a freckle. So in terms of differentiating between freckles, nevi, and lentigo, so freckles are basically like increased pigment in your keratinocytes in your stratum basale. It tends to affect people with fair complexions and increased in pigment due to sun exposure. So your moles or nevi, they're benign tumours of melanocytes, and so they essentially form at the junction between your epidermis and your dermis. And lentigo are basically big freckles. They increase in, they're caused by increased pigment and mild increase in melanocytes, and they're precancerous. Okay, so differentiating between benign and malignant on histology is also important. And I went through this in the first lecture, but basically just to remind you, they're invasive, fast-growing, have irregular borders, don't resemble normal tissue, hyperchromatic, pleomorphic nuclei. They tend to have colour changes and can be hemorrhagic. Now, this one. To be honest, you don't even really need to read the question. You can kind of get the answer anyway. So, yeah, thank you. So basically, it's a malignant melanoma. It's caused by UV exposure, red hair, past history, family history. Sorry, that's risks. So they're basically 4 main types of melanomas. You have your superficial spreading, which look like that. Your nodular melanoma, so it's the most aggressive. Your lentigo maligna melanoma, so basically they tend to present on the face and tend to progress from lentigo malignas. And acral lentiginous melanoma, so those are your palm, sole, nail beds, and they tend to be in dark-skinned people. So these are kind of pictures. So you have your acral, your superficial spreading, nodular, and lentigo. In terms of describing them, so your A, B, C, D, E, so asymmetry, irregular border, they could bleed spontaneously or after minor trauma. Colour variation, so if you have a look at this, you can see the variations in colour. And it has to be more than 6 millimeters and changing over time, so evolving, or they could be elevated as well. So yeah, so this is something that you guys will really need to know, and it's pretty easy to remember as well, so that's good. In terms of grading them, so there are 2 main ways of grading them, so Breslau's depth and Clark's levels. So Clark's levels are basically just indicating anatomically where they've actually spread to, whereas Breslau's depths are in millimeters themselves. So Breslau's depths has a greater influence on the prognosis. So, what do you guys, sorry? Yep, perfect. Sorry? Okay, so basal cells, the most common skin cancer. So that's a nodular BCC. Pearly white edges, telangiectasia, central ulceration, they can be called rodent ulcers. And superficial, so they can be pink macular lesions. Local invasion can be extensive and they may ulcerate. Histologically, they can be basophilic cells, you can look blue, atypical basal keratinocytes, nuclei forming a palisade fence. So those are like your kind of buzzwords. But basically, if you can recognize that this is a BCC, it's pretty good. And so that's nodular versus superficial. So superficial BCCs are a little bit harder to spot diagnose. So the last one, if I'm not wrong. Okay, so the key thing here is that he underwent a renal transplant and has been immunosuppressed. That is, so squamous cell carcinomas are most typically found in people who are either elderly and had sun exposure or immunocompromised. So they are very, very variable in terms of how they look. They can be scaly, they can bleed, they can ulcerate. Bowen's disease is basically the in situ version of SCC, and it's just scaly plaque on sun-damaged skin. Cool, I think that's it. Thank you. And yeah, if you have any questions, email me or ask me. Thank you.